In this video, we'll be discussing the laboratory studies that should be included when admitting a patient with COVID-19 to the hospital, and what laboratory values and findings are helpful in following the course of illness. Her admission laboratory data included a white cell count of 7.4 with 79% PMNs and 15% lymphs, an absolute lymphocyte count of 1.12 times 10 to the third per microliter, hemoglobin of 12.2, BUN of 14, creatinine of 1.14 after hydration dropping to 0.81, a CRP of 44, a D-dimer of 0.67, a ferritin of 724, a CPK of 237, LDH 393, and liver function tests within normal limits. A venous blood gas showed a pH of 7.34, a PCO2 of 43, and a PO2 of 33.9. Her SARS-CoV-2 PCR was positive. I first want to review our latest understanding of how to diagnose SARS-CoV-2 infection. In Module 2, we briefly discussed the use of PCR as well as serum antibody testing. In this video, I will go into additional detail and discuss the recent availability of promising point-of-care antigen tests. In order to better understand the value of different tests, let's look at their relationship to the time course of COVID-19. As shown in this slide from the JAMA, the nasopharynx begins to shed virus several days before the onset of symptoms, approximately 4 days after exposure to an infected person. Nasopharyngeal PCR, solid blue line, and culture, solid red line, correlate closely early in the disease course. However, by day 8 to 9 after onset of symptoms, despite continued positive PCR tests, live virus can no longer be cultured. It should be pointed out that antigen tests is likely to follow the same time course as live virus. Standard nasopharyngeal PCR in some patients can remain positive for 20 to 60 days and does not reflect the presence of infectious virus, but rather persistent RNA fragments of dead virus. Next, note the IgM, purple dash line, and IgG, green dash line titers. They begin to rise about 8 to 9 days after the onset of symptoms and are present in nearly all infected patients by 14 days. IgM titers drop more quickly than IgG titers. As shown in this second figure, the titers are lower in minimally symptomatic patients, blue, and tend to drop to undetectable levels within a few months, while those with more severe disease, green, have higher titers that persist for a longer time. Now let's talk about each assay in more detail. First, PCR. On discovery of the virus, the Chinese quickly fully sequenced it. Subsequently, PCR primers were designed for the segments of RNA responsible for encoding the S protein or spike protein, the N or nuclear capsid protein, the E or envelope protein, and the RNA-dependent RNA polymerase, RDRP. Many of the PCR tests are multiplex. That is, they use probes from all 4 components. They are run simultaneously with a positive and negative control. Therefore, the specificity of most tests is extremely high, greater than 99.5%. These tests are estimated to be able to detect viral counts as low as 10 variants. However, sensitivity is estimated to be only 70-80% because of sampling issues. If the test is performed too early, it is recommended that you wait 3 to 5 days after exposure, or if the test is performed too late, 10 to 15 days after the onset of symptoms, the quantities of virus in the nasopharyngeal samples are likely to be low, yielding a negative result. At the present time, PCR is the diagnostic test of choice to determine whether a patient is infected. However, this test usually takes considerable time to return, 12 to 48 hours. And as the number of new cases has increased and testing centers in the U.S. have become overwhelmed, this has led to delays in reporting of up to 10 days. Delays of greater than 48 hours defeat the purpose of the test. Another concern is the test's low sensitivity, 70-80%, which means that this test has a 20 to 30% chance of being falsely negative. Therefore, if a clinician has a high clinical suspicion that their patient has COVID-19, the test should be repeated. The FDA has recently released 2 point-of-care antigen tests in the U.S. under Emergency Use Authorization, EUA, and these tests promise to overcome the time limitations of PCR. Similar antigen tests are also becoming available throughout the world. The problem in the past with antigen testing of other pathogens has been their low sensitivity. The Becton Dickinson SARS-CoV-2 antigen test is reported to have an 84% sensitivity and a 100% specificity as compared to PCR. That means the test sensitivity is 67%, assuming PCR has an 80% sensitivity. The Quidel Corporation Sophia 2 SARS antigen FIA in a head-to-head comparison with PCR was 96% as sensitive as PCR. Therefore, its sensitivity was 76.8%. These immune-based assays can be performed at the bedside, taking only 15 minutes. Because of the low sensitivity, if there is a strong suspicion of disease, a negative antigen test should be confirmed by a PCR test. Because of the rapid turnaround time, they have the potential of being very useful screening tools for identifying asymptomatic and pre-symptomatic patients, particularly in areas where there is high prevalence of disease. Please see the next video describing how to apply Bayes' theorem to maximize the value of individual tests. At the present time, the value of the SARS-CoV-2 antigen test remains to be substantiated by a large clinical trial. Antibody testing, as discussed in Module 2, is primarily of interest for epidemiologic studies designed to assess the prevalence of disease. These tests are not recommended for diagnosis because reliable levels of IgG and IgM antibodies directed against the virus are not seen until 14 days after the onset of symptoms. The potential role of antibody tests for assessing immunity remains to be clarified. In addition to standard CBC and metabolic panel, we have found several tests to be helpful for monitoring the progression of this disease. Tests likely reflect cytokine levels include C-reactive protein, CRP, D-dimer, and ferritin. LDH may become elevated with extensive lung involvement. An elevated CPK may reflect myositis. And troponin levels should be checked on admission to assess the potential of myocardial involvement. Absolute lymphocyte count is helpful in assessing prognosis, a low count being a bad prognostic sign, and tends to be low when viremia is high. We include these tests in our admission and progress notes. The tests that I have found most useful are CRP, D-dimer, and absolute lymphocyte count. Here is an example of a progress note just prior to our patient receiving convalescent plasma. As you can see, all markers were positive, indicating severe disease, and her lymphocyte count was below 0.8. Also, her oxidation was poor with a low P to F ratio, and her Rothman Index was low. We also follow procalcitonin levels, and when low, that gives us confidence to observe off antibiotics. In her case, procalcitonin increased, forcing us to temporarily institute broad-spectrum antibiotics. Here is a chart showing her key markers over time. As you can see, all parameters steadily worsened after admission. Her CRP increased from 44 to 211 on day 2 and 354 on day 3. D-dimer increased from 0.67 to 2.41 and then to 5.51. On day 3, her IL-6 level was elevated at 48, normal being 0 to 16. On day 5, plasma PCR documented that she had SARS-CoV-2 viremia. Her lymphocyte count dropped to 0.48 on day 6, encouraging us to administer convalescent plasma. Note the subsequent improvement in the lymphocyte count that correlated with her clinical improvement. 48 hours following administration, her lymphocyte count rose to 1.16 and ultimately rose above 2.0. In our hospital, we also monitor the progress of our patients using illness severity index called the Rothman Index that incorporates 24 parameters automatically populated from the electronic record. This includes 10 nursing evaluation scores, 7 vital sign parameters, and 7 specific laboratory values. The score ranges from 100 to minus 91. A high number means your patient's condition is improving or the patient is well, while lower values indicate a poor prognosis. A negative slope indicates progressive deterioration and warns of impending arrest. When appropriately used, this index has improved the speed of rescue, reducing mortality in some institutions by as much as 30%. Note the dramatic drop in her value from 75 at admission to minus 6.5 at the time convalescent plasma was administered. Note the progressive improvement in the RI following its administration. In a separate set of videos, Dr. Camille Petri will be discussing the definition of ARDS and the key principles that were applied to manage our patient's illness in the MICU. To summarize the content of this video, PCR is presently the diagnostic test of choice for diagnosis of SARS-CoV-2 infection. This test is highly specific, but is only moderately sensitive. Turnaround time can be a problem. Antigen tests have recently been released. Their rapid turnaround time is an important advantage. They are moderately sensitive tests, and their effectiveness remains to be proven. Antibody testing is useful for epidemiology studies, but should not be used for diagnosis of active infection or to infer immunity at this time. Useful laboratory studies to follow disease progression include CRP, D-dimer, and absolute lymphocyte count. Subsequent videos will describe how to apply Bayes' theorem to guide testing, how to manage COVID-19 in the ICU, and how to manage moderately ill cases on the medical surgical floor.